Pierluck, then good evening everyone, and thank you for coming here, Joe and Reinhard, and sharing your personal stories, because that is difficult to do and shouldn't have to be done, but I can understand why you do it. And to all of you for the fantastic work you do. I suppose I've had contact from constituents who maybe have an acquired brain injury due to a stroke maybe, or an injury sustained some way, and they would tell you that they get excellent acute care, had a good experience in the National Rehabilitation Hospital, were lucky enough to be able to go home to their own home, like it wasn't a nursing home, and then nothing. And then it's regression. It's led to family breakdown, mental health issues, because the supports are not there in the community. So, they might need physio, or, and like when you talk about people over the years, they seem to have been abandoned in nursing homes, turned once or twice. That's a living hell. Like, that has to be, that's outrageous, like that's something that's happening. And I'm presuming like the neuro mapping project is for the purpose of saying, right, where exactly people are, what services they need, and you need to have that done in order to ensure that the service you provide is adequate. I mean, otherwise, the strategy's been there, and you say it's a good strategy, it's been around a while. But why exactly has it not been in place? Is it all about funding, or is it because there's a lack of, the staff that's required? I mean, the framework was only, I think, 2019, 2020. I know that's now working on, 4 or 5 years since the framework for implementation. And you're saying it is improving, but I suppose if we could give it an overview of where you're coming from and where it's at now and where it needs to get to, and what's required to get it there, and also, I mean, if rehabilitation isn't available, there are costs. So there could be acute cost, hospital care, even nursing home care. I mean, has anyone done? I think you have done something in MSR on the cost of not having rehabilitation. So it would be interesting to know, I mean, what that's at, or how much can be saved by having the proper services. But people deserve their dignity, and the UNCRPD is all about that, and that's what we should be ensuring, that people are able to live their best lives. So, so just if you could maybe just say, what's required and what you would like if the strategy was going to be implemented tomorrow, what would be the priorities to make things better immediately? And I know it's going to take time to build on those.
Okay. Madeleine, do you want to comment? Or Oren, we'll start with Oren so far.
On the costs there, just on a rough search this morning before we came in, according to an Irish Times article, in 2018, the average rate for a public nursing home was €1,564 a week. So for one person for 52 weeks, that would be €81,328. If you took 26 of our clients, let's say, I was just thinking about that, weren't able to live at home and had to be in a nursing home, that's €2.1 million. And if you look at what Reinhard has said that our asking price is, it's a bit of a saving, I would say. And that doesn't bring into account if these people weren't in a nursing home, if they had to be in an acute hospital. A quote from Taoiseach Harris from a committee meeting in 2019, the average daily running cost of an inpatient hospital bed across the acute hospitals is €878 per night. So again, if you want to do some maths on a week's stay or a month's stay for someone that wasn't getting these interventions like you just said, the things that we're trying to implement are, if you look at the health economics of it, I suppose, it's a short-term investment, let's say, for a long-term gain.
There, just around, Deputy Tully, you referenced some of our own research within MS Ireland. So, for example, we've a piece of research that stated that delaying and reducing disability to people just living with MS, now it's not including any other neurological condition, can save the state up to €19 million per year. So, for example, one of our programs that we're trying to implement at the moment, we've a business case submitted for, is our physiotherapy program, which can we have pilot projects running in the West and the Midwest called Active Neuro, which we have data out of, thank God, in terms of reduction in healthcare utilisation of after this project of 43%. We have 49% reduction in the number of people falling. If you think about the average cost of a hip fracture being about 12 and 22,000, 4 hip fractures, prevention of those can pay for a senior physiotherapist in one CHO. So for an investment of 880,000 per year, you're saving about 18 million to the state. There's also another piece of research that we had in 2022, which is the societal cost of MS. And this was as a whole in terms of both direct, indirect and intangible costs to society. And that was committed, that was €483 million per annum. But yeah, so I'm going to hand over to my colleague Magdalene Rogers just to answer the rest of your questions.
Very important on the cost. I think what you've said, Deputy Tully, on that cost of rehab piece. So. I think my colleagues here from UNCRPD and MS Ireland have done, the longer term costs, but there is also the immediate, the bed days, people not being transferred out of acute hospitals because there aren't rehabilitation. And there is a report just recently issued by the HSE actually on that, on the delayed transfer of care because of not having rehabilitation services. I'll ensure that you get a copy of that report. So certainly that work has been done and highlighted, as you said, a really important point here that, for many reasons neurorehabilitation needs to be put in place, but also for the effective running of our health services, that there is that transfer, that people can move on from, as you say, an acute care that's very good, onto the longer term support services. And you asked a very good question, what needs to happen, what has been done, what needs to happen. We have seen the progress, as I said, from the outset, and we've all said from the outset, the community neurorehabilitation teams, there needs to be 9 of those around the country. We still have gaps in those. In terms of, we have 2 major gaps in the neurorehabilitation strategy at the moment. The inpatient beds, which the HSE report just last week is showing for the first time the extent. We always knew there was a very significant deficit in neurorehabilitation beds. The HSE report last week is really, really stark on just the overall deficit. We have a 58% shortfall in the number of neurorehabilitation beds around the country. What is that doing? It's meaning that people are in the regions aren't getting access to neurorehabilitation in a rehabilitation setting. It also means that the National Rehabilitation Hospital in Dún Laoghaire is just becoming a funnel for all neurorehabilitation referrals, which it's never meant to be. It's a complex specialist centre for a particular type of rehabilitation, but everyone, there's now, such pressure on the National Rehabilitation Hospital, and we see waiting lists of 3 to 6 months. On an ongoing, we've almost become used to long waiting lists in the National Rehabilitation Hospital. We almost don't question them anymore, but it's because of that lack of beds around the country that everything is funneling into the NRH. And finally, we have that major gap in the long-term rehabilitation services, the likes of the MS Ireland's, the likes of UNCRPD, where, as you say, we have those pockets of service, but we don't have them all around the country. We don't have equal access to them. And those are the 2 pieces, Deputy, just to answer you, where I think the neurorehabilitation strategy still has a lot to do.
So if you calculate the cost, so it's right to look at the cost of patients or clients and beds and care, but there's additional costs around that. So Joe just said what his wife is doing. I can say the same about Pat. Pat is running a company that provides carers for Porrick. That's a full-time job. Both Pat and myself gave up our day job where we were doing productive work, and we could still be doing that, but we can't do it because there's no services that help us to look after our son. And that's not just our case, that's everybody's case. Mm-hmm. Everybody who's in the gallery, they're all, it's not just the person directly affected by the incident or by the event, it's the whole family, the partners, the parents, daughters, sisters. It's everybody. So there's a huge cost society in that as well. That usually is sometimes is overlooked a little bit. Just to add some personal experience with the NRH. So it's not 3 to 6 months. So we went to Germany when Porrick had the accident in Cape Cod. He came back to Dublin. Then eventually was seen by consultants, and we were told that there would be a waiting list. That there would be a waiting time of a year. And we have heard that from other clients in UNCRPD as well. So the waiting time of a year, and then the time in the NRH was predetermined, so it was not dependent on the condition of the person. Everybody who was severely affected was going to get 3 months. And those 3 months were not so much about getting the people better. They were getting some interventions, clinical interventions, but it was not to get them better, it was to assess them. They wrote 2 books that explained, and they basically planned the rest of their lives there. So when they were going to the nursing home, the nursing home would know how to feed them, how to position them, how to transfer them, all that kind of stuff, and that just took 3 months. And in some cases, a home care package was arranged. That was what the 3 months were for. And after that, people, and there has been scientific research about all of this, people fall off a cliff, and that's it. You get out of there and forget about it. So there's a need for ongoing, for an ongoing service in the community, and the reports that we have reports of meters high of reports. We have a review of our service that looked at it in detail and probably cost the best part of €100,000 to produce that, and it has recommendations in there. We are ready to deliver that. So why are we not allowed to do this? It's hard to understand that, and that's where we have lots of people to help us to do what is needed, what people have told us is needed, what the families are looking for, what they have experienced is a really, really good service, and let's do it. And what we need is the funding for next year to start building this centre that will coordinate centres around the country, not just for Dublin. So, can I just some very, I forgot to say, could I? Yeah. So it's not just a clinical approach, and we are talking here about human rights, and we're talking about the convention. I have a full page here of laws that are potentially being breached, and that you can look at the Constitution in Ireland. You could look at European legislation and international legislation, and they all demand that people with disability, and it doesn't matter what level of disability they have the same rights as people that are sitting here. Imagine your husband, your wife, your son, your daughter was in a situation like that, and you were told, well, if he doesn't get better, we'll just keep him comfortable. I mean, that breaks your heart. It's hard to imagine anything worse, and that interventions, of course, they have to be paid for. But people also have a right to those interventions. We talk about equality, integration, participation, all those things. And it's possible to do it. We have shown that it is possible. Paul goes to concerts, he goes to Germany, visits his family there. Other people go into the botanics and we go swimming. You can do all that, but you need the right support to do it. And we are there, we have it, but it needs a push over the line.
Okay.
And hopefully you can help us with that.
Absolutely.